Hello, everyone, and thanks very much for joining us today. Welcome to our webinar for an update on the development of newborn screening guidance in Canada. I'm Dan Singh. I'm the Director of Strategy and Innovation at Canada's Drug Agency. And as part of our organization's work to support the National Strategy for Drugs for Rare Diseases, we've convened a panel of experts to provide advice on newborn screening in Canada. And I'd like to introduce you to the panel co-chairs who will be leading our session today. Dr. Hilary Vallance is the Medical Director of the BC Newborn Screening Program and a medical biochemist and biochemical geneticist at BC Children's Hospital. She has over 50 peer-reviewed publications on newborn screening and inborn errors of metabolism, and some of her research has been in partnership with British Columbia First Nation communities. Whitney Ayoub-Goulstone is the Executive Director of Immunity Canada. Whitney is also the past chair of the Network of Rare Blood Disorder Organizations, a board member of the International Patient Organization for Primary Immunodeficiencies, and a member of the Patient Network for the APEC Business Ethics Forum. And she's been working in the patient advocacy and engagement for over 15 years. Next slide, please. Before we proceed, I would just like to acknowledge this land on which our Toronto office operates. Since time immemorial, it's been the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now the home to many diverse First Nation, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13, signed by the Mississaugas of the Credit, and the Williams Treaty, signed with multiple Mississaugas and Chippewa bands, and we are so grateful to have the opportunity to work on this land. Next slide. Turning to the agenda, today we'll be sharing background on the advisory panel and their guidance and how you can be involved and share your input. All of the associated material has been posted on our website, and a recording of today's session will be uploaded there as well. We'll share some information about the development of newborn screening guidance in Canada, as well as a high-level summary of the panel's proposal. And we've saved some time to take a few of your questions, which you can submit by hitting the Q&A button in the Zoom window. And I'll hand it over to Whitney.
Thank you, Dan. And thank you all for joining us today on behalf of myself and my co-chair, Hilary. I'm really happy to be here. I'll begin by giving some background on newborn screening, the advisory panel, and the scope of our work. The Government of Canada announced a total investment of up to $1.5 billion over 3 years in support of a national strategy for drugs for rare diseases, DRD, in March of 2023. Early identification through newborn screening for rare diseases is an important component to support Canada's national strategy for drugs. One of the key activities to support this strategy is to establish an ad hoc newborn screening advisory panel to provide credible, strategic advice and expertise to highlight promising practices and evidence-informed discussions for newborn screening programs in Canada. Next slide, please. It's important to note that in Canada, newborn screening programs are established and funded by the individual provinces and territories. Newborn screening helps to identify treatable conditions as early as possible and prevent serious health. Early identification of rare disorders through newborn screening can lead to more timely diagnosis and appropriate access to treatment and supports early in life. Blood spot newborn screening began across Canada in the 1960s, first with screening for PKU, a treatable genetic metabolic disorder. And as new technologies emerged, newborn screening programs across the provinces and territories expanded to include tests for other conditions, such as congenital hypothyroidism, and now more than 20 different treatable conditions. Next slide, please. While much progress has been accomplished in the area at the provincial and territorial level, there is an opportunity to help foster greater consistency on the conditions screened and to support continuous quality improvement in the screening process. We know that as many as 60 new transformative cell and gene therapies could come to market in the next 10 years. In the next few slides, I'll provide an overview of how we're building and leveraging existing work, how we intend to engage with interested parties about our newborn screening project, and about the advisory panel and its mandate. Next slide. Okay. There has been tremendous work done in newborn screening to date. We're building on the learnings from provincial and territorial newborn screening programs and processes as well as recommendations made by the 2016 Intergovernmental Newborn Screening Working Group and a report by Immunity Canada and the Network for Rare Blood Disorder Organizations in 2022. In both these documents, we've considered the details of the recommendations that were made, including having Secretariat supports to review emerging screened conditions, adopting on a set of agreed principles and criteria when considering adding conditions on a panel, and having a pan-Canadian newborn screening advisory committee to provide guidance, which is why we're here today. Next slide, please. So the advisory panel. To support this opportunity to enhance pan-Canadian coordination of newborn screening programs, Canada's Drug Agency has hosted an ad hoc, time-limited advisory panel, which is composed of 2 co-chairs, Hilary and myself, and 11 members who come from across Canada and represent diversity, including sex, indigeneity, and race. The advisory panel brings together a range of expertise and experience, including healthcare providers, which include clinicians, program administrators, researchers, as well as persons with lived experience, and individuals with backgrounds in bioethics, law, and health administration. If you'd like to know more about the members, biographies, names, conflict of interests are all available on the CDA AMC website. Next slide, please. The advisory panel, so our work to date, our advisory panel has met 4 times since January 2024 and has developed a draft guidance. We're now at our engagement stage, which today's webinar is a key part of, and we're inviting input into the draft guidance, which has been presented in the discussion paper. After reviewing the input that we receive, the advisory panel will consider what we've heard and meet to revise and make a recommendation. The final report will be submitted to Health Canada and provided to the provinces and territories and will be made public in March 2025. Next. Thank you. A key part of this project is to actively engage with interested parties in a timely manner and to provide sufficient opportunity for individuals and groups to provide constructive advice and meaningful feedback. We're inviting you to share your feedback with us on the discussion paper through an online consultation forum. In following our guiding principle on transparency, we'll be publishing the written feedback submissions we receive in full with all personal information. We're planning to host a second webinar in winter of 2025 to share what we've heard. To be involved, you can access a discussion paper which presents the proposed guidance. It will be online, and we'll tell you more about accessing that discussion paper. And then after reviewing the guidance and the questions, you can submit your response through the online forum. You'll be able to save your responses and complete the questionnaire, so you don't need to do it all in one sitting. And the online feedback period is open from today until September 11th, 2024, so 2 months. And as I said, we'll be publishing all feedback we receive in full. Now I'll tell you a little bit about the advisory panel's draft guidance. The advisory panel identified 6 areas where there was a need for guidance for enhancing the coordination of newborn screening. I'll speak briefly to each component so you can get a sense of what the key proposals are. The next slide, please. The draft guiding principles set the foundation for the advisory panel's work and were used to inform and shape decision-making when developing processes, criteria, and a proposed list of conditions to screen for in newborns. These draft guiding principles are a core set of aspirational values that serve to guide the advisory panel's exploratory vision for a potential coordinated newborn screening system and activities in Canada. And now I will talk a little bit about our proposed draft guiding principles. These include health rights of the newborn, equity, effectiveness, safety and quality, transparency, collaboration, and sustainability. Health rights of the newborn is central to the activities and decision-making considerations. Given the goal of newborn screening is to improve the health of newborns, members of the panel felt that health rights of the newborn to achieve the highest attainable state of health should be granted primacy and viewed as an overarching principle of all newborn screening activities. There was a consensus as well that equity is critical for all newborns in Canada across geographical and cultural contexts. Equity needs to be considered for all aspects: the screening test, follow-up, diagnostic testing, and treatment services. Newborn screening is part of a continuum that includes the initial screening test, short-term follow-up of a positive screen through to diagnostic testing, and access to treatment, and that this continuum needs to be effective, safe, evidence-informed, and of high quality. Transparency is an important factor. To support trust and foster accountability, it was noted that future decisions and processes relating to newborn screening needs to be transparent, clear, and impartial. There was an identified need as well for effective collaboration between newborn screening programs. The principle of collaboration also applies to inclusive and meaningful engagement to ensure the values and diverse perspectives from across Canada are embedded in newborn screening activities. Last but not least, sustainability was considered as a driver for newborn screening, which included balancing the current needs within the healthcare system and the needs for future generations. For full definitions and the advisory panel's rationale for deciding on these guiding principles, they can all be found in the discussion paper, and our online consultation form is asking for your perspectives and opinions on these proposed guiding principles and their definitions. I'm now going to pass it over to my co-chair, Hilary.
Thank you, Whitney. We're now going to explore a future model for newborn screening in Canada. Each of the provincial newborn screening programs has developed their own approach and processes to review and add conditions to their respective newborn screening test panels. This has led to some differences in the conditions screened across the country. Since there is currently no coordinated approach to newborn screening in Canada, the advisory panel set out to explore what a future coordinated model for newborn screening in Canada could look like. Next slide. Building on previous recommendations from the Intergovernmental Working Group, and more recently from Immunity Canada and the Network for Rare Blood Disorders, the advisory panel was tasked to propose a strategy for test panel review to enhance uniformity for newborn screening practices across the country. A coordinated approach enables efficiency in test panel review, mitigates risks, facilitates quality improvement, and supports timely response to emerging advances and challenges across the newborn screening ecosystem. A formalized, coordinated newborn screening model may also support greater consistency and efficiencies within provincial territorial health systems by enhancing lines of communication and information sharing. Next slide. The figure in this slide represents a high-level illustration of what a potential coordinated system could look like. The intent of the proposed coordinated model is to complement jurisdictional newborn screening programs by supporting alignment across Canada, with provinces and territories retaining autonomy to tailor their newborn screening programs to local needs. The overall vision considers using an advisory coordinating body to house and support the integration of the proposed structure into our health systems. A coordinated structure could potentially be housed within one organization to ensure continuity, collaboration, and alignment of goals and objectives. Information sharing, collaboration, communication between provincial territorial ministries of health, newborn screening programs, and across all committees was also identified as an important component to support the successful implementation of newborn screening work across Canada. The details about each of the proposed committees, roles, functions can be found in the discussion paper. I'll highlight a few key functions of the committees just to provide you with a sense of their roles. Starting with the proposed Newborn Screening Advisory Committee. Such a committee could provide a coordinated forum for communication with newborn screening programs and PT ministries of health, build relationships within the broader drugs for rare disease space, provide oversight and advise committees, and deliberate and provide final recommendations on adding or removing conditions. Next, an expert review committee could review nominations, conduct evidence reviews and horizon scans, and draft recommendations. And lastly, some of the potential key functions for the Quality, Standards, and Education Committee would be to provide guidance on best practices and to coordinate a data repository for continuous quality improvement, develop educational materials, and provide learning opportunities for health professionals and the public. Next slide. The full description of this model for a potential coordinated system and the proposed committees with their composition and functions can be found in the discussion paper. Our online consultation form is asking for your perspectives and opinions on the proposed coordinated newborn screening model. Next slide. As we mentioned, given that each province and territory currently has its own process for adding conditions, the advisory panel explored opportunities to enhance consistency through aligning and complementing their processes at a pan-Canadian level. Although historically newborn screening programs have rarely removed conditions from test panels, it is recognized that there are occasionally times when this needs to be considered, and therefore it's important to have a process in place. This situation, for instance, may arise if unexpected harms are identified that might outweigh benefits, or if test performance in practice falls below expectations, or anticipated health benefits are not achieved. There may very well be alternatives to proposing removal of a condition, and this is outlined in the discussion paper under a separate section called reassessment process. Now, in the next slides, we propose a process that encompasses both adding and removing conditions, with the understanding that the process is more commonly used for considering new conditions to be added to the test panel. So we'll start off by looking at the process. The advisory panel explored existing processes that are in current use among newborn screening programs for adding, removing, or reassessing conditions. Relevant Canadian and international sources were identified using a scan of publicly available information. The process to add a condition has 4 steps: a process to nominate conditions for review, a process for evidence review, a process for deliberation and recommendation, and then a process for engagement and communication. Next slide. The first step in the process for nomination would be proposing a target condition. The nomination form would solicit supportive information and evidence to justify the nomination. To ensure equity and collaboration, nominations could be submitted by individuals, including patients, parents, caregivers, members of the public, clinicians, or others, as well as groups or organizations such as patient advocacy groups, laboratory scientists, clinicians, ministries of health, and others. The nomination form would be designed for accessibility and to ensure that appropriate and sufficient information is provided to support the rationale for the nomination. The second step is a review of the nomination for completeness. Nominations with missing information may be returned to the nominator for completion. The next steps involve review and deliberation. Nominations that are deemed to align with pre-specified criteria, which will be discussed in the next section of the presentation, would proceed to evidence review. Nominations that are deemed not to align with the criteria may be eligible for resubmission if new information becomes available. Once a decision to review the evidence has been made, a comprehensive review of available evidence is conducted, and evidence is summarized and reported. The scope, detail, and timeline for completion of the evidence review will be dependent on the available information, technical and methodological considerations. The approach to evidence review will be informed by the proposed guiding principles that Whitney outlined, and will consider the potential benefits and harms of newborn screening for the nominated condition. The following steps involve deliberation over the completed evidence review and development of recommendations. These steps in the process include summarizing available evidence and its relevance to the criteria, engaging in discussion, drafting recommendations to inform the decision whether to recommend addition of the condition to a pan-Canadian newborn screening list. Finally, steps for engagement and communication would complete the process and would be intended to provide an opportunity for broad engagement with interested parties and members of the public. The draft recommendations would be made publicly available, and interested parties could provide input and feedback. This input and feedback would be collated and incorporated into the recommendations as appropriate. Following this engagement phase, a final recommendation would be issued, made publicly available, and communicated to health decision makers across Canada's provinces and territories. A description of each key step in the proposed process can be found in the discussion paper. The online consultation form asks for your perspectives and opinions on the processes proposed for each key step. Now we'll move on to the criteria for adding conditions to the test panel, which also apply to reassessment and potential removal of conditions. In terms of the criteria to add a new condition to the newborn screening list, many jurisdictions in Canada and internationally use explicit predefined criteria. The criteria generally cover several domains, including the condition, the test, treatments, and societal and other considerations, and are often tailored to the condition under review. In developing the proposed criteria, we considered using the 1968 World Health Organization Wilson and Jungner's criteria, which were found still to be relevant and foundational for considering new conditions for test panels. However, the panel recognized that these criteria need to be tailored to the current newborn screening environment and adapted to be relevant to Canada. Examples of modifications include additional clarification that eligible conditions are those that manifest early in life, during infancy or early childhood, as opposed to those later in life, adulthood. To explicitly state that there should be a net health benefit to children, to improve health outcomes with earlier detection, and not just convenience of the blood spot card for testing. And being explicit about equitable access, not only to screening, but the whole path through diagnosis and treatment. The draft guiding principles were considered in the development of these criteria. The advisory panel reviewed several sources in drafting these criteria, including the Newborn Screening Ontario's framework and a consensus document on public health screening published by a Canadian group led by Dr. Mark DeBrow. A full description of the proposed criteria for adding a condition and their linkages to the proposed guiding principles can be found in the discussion paper. Our online consultation is asking for your perspectives on these proposed criteria, and we welcome your input. For removing a condition, the advisory panel reviewed Australia's newborn blood spot screening framework, which outlines one of the few published guidance documents for removing a condition from a newborn screening list. The framework includes questions or prompts that cover similar domains to those in Wilson and Jungner's criteria. I'll just mention a few of these prompts here. All the details are in the discussion paper. So the first is, what is the rationale for proposing to remove the condition from screening? What would be the clinical implications of removing the condition? What positive impacts would removing the condition have on the program for affected individuals, families, laboratories, healthcare providers? What are the risks of removing this condition from screening? For example, the impact on the ability to detect, say, secondary conditions, or the impact on families, including future reproductive risks. Are there any alternatives to removal of the condition? For instance, alterations to screening cutoffs or further follow-up testing. The advisory panel made modifications to contextualize for pan-Canadian decision-making. A full description of the proposed considerations for removing a condition from a newborn screening condition list can be found in the discussion paper. Our online consultation is asking for your perspectives on this topic. Another task of the advisory panel was to review current provincial territorial newborn screening test panels to help inform a future recommended pan-Canadian newborn screening test panel. The advisory panel reviewed previous newborn screening work that was done at the pan-Canadian level in 2016, We identified an opportunity to build on this work as the 22 conditions that were proposed back in 2016 have been adopted or are in the process of being adopted by most newborn screening programs in Canada. The panel would like to thank the newborn screening laboratory scientists across the country and their working group who provided information on test panels from their respective provincial territorial newborn screening programs and for making this information available for our panel review. It's important to note that there are some differences between programs in the way conditions are defined, what we often call case definitions. At this time, the advisory panel is proposing to focus on primary conditions, which are the stated target of screening for this proposed pan-Canadian newborn screening list. The proposed test panel you can see here has some modifications from 2016. First modification has to do with nomenclature. We separated out sickle cell disease into 3 subtypes. So on this proposed list, each is now counted as a separate condition. This modification was proposed to be in line with condition naming and counting from other international newborn screening programs, as this helps us compare apples to apples. The second modification is the addition of 1 new condition, spinal muscular atrophy, which is being added or is in the process of being implemented across all jurisdictions in Canada. During the review of conditions that are currently being screened for by Canadian newborn screening programs, 9 conditions were identified as not being screened uniformly, meaning they've been adopted by 1 or more newborn screening programs, but not all. But in fact, a few of these apparent differences have to do with case definitions. Specifically, all of the carnitine-related disorders on the second row of this slide that you can see there. Some programs classify these carnitine disorders as secondary rather than primary conditions. Data sharing and dialogue between programs will assist in resolving some of these apparent differences. The advisory panel recommends further evidence review to support decision-making regarding all of these conditions, for addition to a proposed pan-Canadian newborn screening list. A full description of the proposed pan-Canadian newborn screening list and the conditions that are proposed for further evidence review can be found in the discussion paper. Our online consultation is asking for your perspectives on each of these. As we just described, the advisory panel proposed a potential starting point for a pan-Canadian newborn screening list. But the newborn screening landscape is always changing and growing with new and emerging health technologies and treatments. Therefore, it becomes imperative to keep close watch over emerging newborn screening conditions. Anticipating the need to review conditions enables more strategic and proactive decision-making. It supports the appropriate allocation of resources, and it helps to prioritize and manage potential condition review requests that are coming in. Through anticipating and monitoring emerging conditions, when new information becomes available or new treatment comes to market, the system is positioned to be ready and primed to support decision-making in an efficient and timely manner. The advisory panel discussed some of the potential emerging newborn screening conditions that are not on current panels in Canada. An emerging condition may be a condition that is being added to or is under review by a newborn screening program in another country. It may also include conditions that have novel treatments that should be monitored for clinical utility and system readiness. Now, this slide outlines examples of emerging conditions that were identified for further monitoring and potentially to be considered in the future, for addition to a proposed pan-Canadian newborn screening list. This list is not meant to be exhaustive. The intent really is to identify key conditions to keep watch of and monitor for early awareness to support health system readiness. The advisory panel is seeking input to identify additional emerging conditions. And I will now pass back to Whitney to discuss next steps.
Thanks, Hilary. How can you provide feedback and be involved in this process? The advisory panel's discussion paper and proposed guidance launches today for consultation, and the deadline for feedback is September 11th, so in 2 months. Feedback can be provided through our online consultation form, and all registrants for this webinar will receive an email with a link to the discussion paper and consultation form. In addition to our online consultation, we'll be engaging equity-deserving groups and other consistent with our commitment to inclusion, diversity, equity, and accessibility through focus groups as well. Through the online consultation forum, we'll be asking for feedback on guidance proposed by the advisory panel, which we heard about. We'll be asking about each of the 6 areas of guidance, looking for your perspective and opinions, as well as any suggestions that you may have. These areas will include proposed guiding principles and definitions, which we've heard about, what a proposed coordinated model for newborn screening in Canada could look like, which Hilary outlined, the opportunity to enhance processes for adding and removing conditions, which Hilary also outlined, as well as things that we talked about, the proposed criteria for adding and removing conditions, a proposed pan-Canadian newborn screening list, and anticipating emerging conditions that could be screened for in Canada. So again, to be involved, you can access the discussion paper, which presents the proposed guidance. And after reviewing the guidance and the questions, you can submit your response through the online form. As I mentioned earlier, you'll be able to save your responses and complete the questionnaire in more than one sitting. The online feedback period closes in 2 months, September 11th, 2024. And for transparency, we will be publishing all feedback we receive in full. Hilary and I are happy to answer questions now. We know that there are quite a few, so if we're unable to answer your question today, please feel free to submit it as well in your online feedback.
Thanks very much. I'll bring forward a few of the questions that have been put into the chat. The first one's easy and I can take it. Will this presentation be made available afterwards? Yes, it will. It'll be posted on our website, which Whitney mentioned. And I think all the participants today are going to get a follow-up email after the webinar, and we'll try to include some links to some of the main material and the places where you can access them in that message as well. All right, the second question, Hilary, I think this one is for you, and it kind of goes back to the 9 conditions that are not uniformly adopted. If condition X is already included into the newborn screening program in some provinces, but not others, would the nomination process to suggest the addition of this condition by the province that does not have it available be the same? I guess it's getting at, does it have to go through all of the steps that we're suggesting?
Right. Yes, it would have to. So I think that what we had recognized is that there is a need to review these 9 conditions, and the idea, I think, would be that we do this within this new proposed structure that we have outlined. That so in a future state, we would have an evidence review committee that will be looking at these 9 conditions and going through them. So the nomination would not be necessary, because I think we are already proposing and committing to doing that work.
So can I just add to this as well? And it's not. So this committee, and I think for clarification too, is looking at, we'd be giving guidance. As Hilary mentioned, the provinces and territories and their newborn screening programs retain their own autonomy as to what conditions remain on their own screen. we as a committee recommend what we feel once everything goes through that process and those conditions, and what conditions we recommend as a committee are then passed on. So it gives those, it's a guidance. So we say as a committee, once that's agreed upon at the committee level, these are the conditions that this committee recommends to the provinces and territories include on their screens. But we don't mandate to the provinces and territories as a committee what to screen for or not to screen.
Yeah, absolutely. And there could very well be local considerations.
And I will also say just the nomination process, because it varies from province and territories, we are making a guidance as to what a nomination process looks like, so that it's and that review process looks like, so that there is consistency across the programs, and there's consistency across. This is the overarching goal is to create equity and create consistency across the country.
Thanks. I think this next one might be for you, Whitney. Can you clarify if there were any people with lived experience involved in the panel?
Yeah, so we do, as I said, we are doing our best for the makeup of the panel to ensure that we have a diverse representation from lived experience, as well as from that, to bring those context experts and the content experts together, so that we have a makeup from across Canada to kind of bring that demographics together. So yes, we do have the patient representatives or lived experience representative on the panel. We have two on the panel, as well as the programs and lab and healthcare representatives.
Thanks. Another clarification question. I think this one might be for Hilary. Can you clarify that this newborn screening program is specific to blood spot testing?
Yeah, so we have so far focused our discussions on blood spot screening, and we actually, I don't think, have had any discussions about expanding that scope at all. And we have not yet actually included, I don't think we have any definitions in the discussion paper. So I'd say that's a really good question, and I would invite whoever has submitted that to send that in to our group for consideration. Perhaps we do need to put in some definitions in the discussion paper in terms of defining scope.
Yeah, thanks. I think this one's for you, Whitney, and it goes back to the principles around sustainability. Did you consider actionability now or in the future, i.e., what are the downstream effects of screening on children, families, and health systems?
Wow, that's actually a great question. And I think that would have to go back to, the entire committee. We discussed a lot. I don't know if that speaks to sustainability of the program itself, but we did look at actionability in some ways, because we looked at, what is the point if we can't actually follow through with consistency and quality. And we talked a lot about the harms and benefits. The benefits need to outweigh the harms. But we also talked about if we looked a lot about if there's no treatment, or if there's no testing centers, or if the timing of tests, the quality of tests. So we did look a lot at actionability in many ways. I don't know if we ever considered the term actionability as a guiding principle, but I think actionability follows through in the effectiveness component for, but we may want to look at maybe putting it in somewhere. So that's actually a good question. But I know that we did, it definitely follows through in a lot of our work.
Great. Another one for you, Hilary. What is the role of genome sequencing in this process?
We briefly touched on genomic newborn screening during our meetings. And we're aware that internationally there are several pilot studies evaluating genomic newborn screening. There are a number of approaches being evaluated to multiplex gene testing to identify treatable genetic conditions that affect children. It could be in scope in the future, but I should point out that the current genomic newborn screening pilot studies that are happening internationally are being done under a parental full informed consent process. And currently in Canada, we do not have that for newborn screening. This is in contrast to what the state right now, where we have implied newborn screening. We provide information, we endeavor to educate, but the actual process of newborn screening is actually happening essentially without informed consent. This makes the assumption that the vast majority of the public accept newborn screening, and that it's the premise that it is in the best interests of the child. And so there are risks to genomic newborn screening, and there's an understanding that perhaps not all parents may consent or may not want genomic newborn screening. So we discussed it. We felt that on a horizon, looking at a horizon scan, that we have a huge amount of work to do, and we think that it's likely that this will be within scope in the future, but it's not within our current horizon to consider genomic newborn screening.
Thanks. Back over to you, Whitney. Has thought been given to how to deal with these regional peculiarities or variability, I guess?
Yeah, absolutely. We did discuss, I mean, obviously, we're looking at conditions for a pan-Canadian list, but there's been a lot of discussion about regional, I'm assuming that's what this question is regarding, is regional variance. So we did discuss a lot about certain conditions that are on regional or provincial newborn screening lists that would not necessarily be in consideration for other newborn screening lists. So we did have many discussions regarding that. And I think we need to continue to be aware. We discussed how we just need to be aware and open and kind of work to be mindful of that there will continue to be, because Canada is so vast and our demographic makeup is so different, that we just need to be mindful that there may not be certain conditions that will be for the pan-Canadian list because of these regional makeup and differences.
Thanks. Over to you, Hilary. Will this panel be supported to act as an evidence review body for the long term, or is it a time-limited panel?
That's a really good question. I don't know the answer to that. I think that we're hopeful that we can create a national framework that is sustainable. This committee, this panel is an ad hoc panel, but what we are hoping for is a sustainable national framework where these kinds of test panel reviews can be done. And so, yeah, I think we're hoping for sustainability.
Yeah, I would just add the scope of the work as it relates to supporting the National Strategy for Drugs for Rare Diseases is time limited, but the goal is to have something that is sustainable beyond that. All right, I'll keep going back and forth. Back to you, Whitney. If a condition is nominated, does the nominating organization have the opportunity to submit supporting information, sort of exerting an appeal or resubmission mechanism?
Yeah, so at the moment, as Hilary pointed out, this is still very early process, right? So we're at a point where we're in the discussion phase. We're asking for your feedback. We've laid out a very high-level strategy on what we feel this could look like and what the nomination process could look like to work. But please include your feedback of what you think should be included. We envision a nomination process where the nominating party can bring in supporting documents, and that's what we think. But please read the discussion paper and include what you feel. If something is missing, if you think actually no, we think this should be included as well, then please give us your feedback.
Thanks. Another one for you, Hilary. Is there any stance on screening for diagnosis, i.e. existing conditions versus risk, i.e. a potential for future development of a condition? And I guess the example is such as the case for congenital hearing loss.
Can you read that again? I think I want to understand this.
Sure. I guess it's is there a stance on screening for diagnosis versus risk, right? So the existing conditions versus the potential for future development of a condition.
Oh, yeah.
And then congenital hearing loss was cited as an example.
Yeah. Oh, I mean, that's a great question. I think that's up for debate. I don't think I can answer that question. That has a lot to do with balancing benefits and harms, and has a lot to do with understanding what the public wants as well, and whether it has broad acceptability. And so I really don't know the answer to that. Yeah, good question.
Yeah, thanks. Another one for you, Whitney. How will this work be connected with ensuring access, including reimbursement, to innovative medicines?
Oh, I love that question. Oh my goodness. Such a big question too. I don't know who asked that, but feel like that might, anyway, that's a great one. Okay, so I don't want to delve too deep into it because we could be here for another hour in discussion, but the hope is that as we've said, this is really an ad hoc committee where we are to examine what it would look like to have a model for a pan-Canadian newborn screening program and infrastructure. And then the report will go to Health Canada and the provinces and territories, and hopefully be a sustainable model. If it is to become a sustainable model, then it would create greater access and equity in newborn screening in Canada, which would allow for better health outcomes, hopefully, and for these rare disorders and other disorders that are treatable in newborn screening. As I said in the presentation, we know that there are many more advanced therapies coming in down the pipeline. Hilary showed some emerging conditions and spoke about emerging conditions that are coming in. So it hopefully will allow for advancements in market access, allow for advancements and timelier advancements in market access and treatment and diagnosis across Canada, and equity for those. So that's the hope. The hope is that by working together and in collaboration, which is one of the guiding principles, we advance therapies as well as access, as well as treatment and diagnosis in Canada for these rare disorders.
Thanks for that. Back to you, Hilary. Are you envisioning this Canadian NSAC would be sort of like the American RUSP or RUSP?
Yes, similar. There are some differences in the States. In the States, they have it's a bit more directive. Like in many states in the U.S., screening is mandatory. And my understanding is that decisions that are made on the RUSP for some states is interpreted as a mandate, as binding. That is not what we're envisioning in Canada. These decisions are non-binding; they're recommendations. But we've looked carefully at the U.S. model, and we actually met with a couple of the leaders who are involved in test panel review a lot, as well as with New Steps. And there's lots to be learned there, and they have a wealth of experience, and so certainly they are an important model But I don't think that we see it as being quite the same here in Canada.
All right, thanks. We'll take two more. This one's back to you, Whitney. Do you envision the framework can and will evolve over time, particularly when costs of screening could drastically reduce with better technologies?
Yeah, I mean, I hope that this is like everything. I hope that there is an ever evolving model that grows. I hope that it goes forward and that the work doesn't end with this, ad hoc time limited panel. I hope that it finds a home. I hope it finds a permanent home somewhere in this infrastructure that we have, and I hope that it evolves. I hope that it grows, and as the question says, we see that testing is changing, so the costs are coming down. We know that there are more disease states coming in that will be more and more conditions we'll be able to screen for. We know that there's more and more therapies coming in. So I think that things will have to evolve and grow. Yeah.
Thanks. And I'll take this last question. It's whether are the conflicts of interest for the panel members declared? They absolutely are, and that information is available on our website. And maybe as I wrap here, I'll just thank everybody for taking the time to sit and listen with us today, and to our co-chairs for taking us through the information and answering some of these questions. We look forward to engaging with you more through the opportunities that were mentioned and that are posted on our website. And I hope this information session was informative, and we're really looking forward to moving this work forward. So thanks again.
Thank you, everybody. And thank you, Dan, for moderating. And thank you, everyone, for attending.
Thanks.